We'll get right into it. My topic is a little bit specific. We got a short time here, so I thought I'd cover a little bit about prostate cancer screening. This is something that we see quite often in our office, and patients often have questions. Even when they come in for other problems, they'll ask us about, should we have our prostate checked for prostate cancer? Sometimes they'll read things where they say that they shouldn't have it checked. So I thought it would be a good topic to just sort of quickly summarize. So just a little bit about prostate cancer. It's hard to see probably far in the back here, but this graph just shows the different causes of cancer-related deaths in Canadian men. And the most common there, lung cancer because of smoking history. Colorectal is a second, and then a close third is prostate cancer. So it's the third most common cause of cancer-related death in Canada. The lifetime risk of death from prostate cancer in Canadian men is about 3.7%. So 1 out of 27 Canadian men will die from prostate cancer. In terms of the risk of diagnosis, it's much higher, so about 13.6%. So 1 out of every 7 Canadian men will be diagnosed with prostate cancer. The known risk factors that have been proven through research are age, family history. So in particular, first-degree relatives. If your brother or father had prostate cancer, that's a strong family history. Race, so we know that in the patients that are of African or Black ancestry, they tend to have a slightly higher risk for prostate cancer, and obesity is another one. So what is the prostate? What does it do? And what is prostate-specific antigen, which is the test that we're going to talk about. So the prostate, this is an organ that's part of the male reproductive system, and it lies in between the bladder and the penis, within the pelvis. So this is a picture here. Just at the top there, you have the kidney where the urine is produced. It comes down the ureter. The bladder is right here where the urine is stored, and the prostate is just below. And it's almost like a donut-shaped organ. And so when you pee, the urine flows through the prostate and out through the penis, through the urethra. So the function of the prostate is to provide a fluid in which sperm can maintain a healthy sort of lifespan, and it can travel to the location where they're intended to travel and best achieve their goal, which is essentially reproduction, right? So fertilization of a female egg. So that's what the prostate does. The way I sometimes explain it, just so lay people can understand, is if you, I'm sorry, I'm gonna ruin Cheerios for everybody, but a bowl of Cheerios. If you imagine the Cheerios as sperm and then the milk as the fluid in which the sperm in which the Cheerios float, that's essentially what the prostate does. It produces the milk in which the sperm travel. What is PSA? So PSA is also known as HK3. This is a protein that is produced by the prostate, and particularly it's a type of enzyme which is used to break down other proteins. It functions in the semen in order to maintain the semen in a liquid form. So without it, the semen would coagulate and it wouldn't be able to do what it's supposed to do. So that's what PSA does. And it's also then found in the blood, and it can be tested to our advantage to identify patients that might have a high suspicion or risk for prostate cancer. So what is a screening test, first of all, right? Screening test is basically the use of a test across a healthy population to identify individuals who might have a disease. In this case, we're going to be talking about prostate cancer, and we want to try to catch it before they develop the symptoms. So a lot of times patients will come and say, "Doc, I'm totally fine. I pee totally fine. I don't have prostate cancer." But this can be a misconception because oftentimes when prostate cancer presents early, there's no symptoms whatsoever. So this is where screening tests are really helpful. So what is the component of a good screening test? How can we know a screening test is worth its while? So first, there's some factors that are related to the disease. The disease has to be common enough in the population that it can be detected, and it should be a lethal disease. In other words, if it's a benign condition, then we don't really have to worry about finding it earlier. We also want to be able to understand the natural history. So how does the disease progress over time? Because that's going to help us then treat it if we can catch it earlier. We want to have good treatments available for the disease. We don't want to detect it without there being sort of shrug your shoulders at the end. We can't do anything about it, so that's another factor. And there should be demonstrable benefit where detecting the disease earlier will improve outcomes, survival, and your quality of life. So there's test-related factors as well. So the test has to be a good test. You have to be able to pick up prostate cancer with good sensitivity. The test should be able to detect the cancer at an early stage. It should be cheap. It should be non-invasive, because if we're going to administer it to a wide population, they're not going to want to incur a lot of inconvenience and potential risk from the test. It should be easy to administer. So screening for prostate cancer, as I just alluded to a short while ago, is done via the PSA blood test and also via a digital rectal examination. So that snap of the gloves you see on TV, the cartoons, and the doctor's getting ready to pass his finger, that's what we do. So screening for prostate cancer with the PSA and the rectal exam helps us determine when we should take the next step. The way that prostate cancer is diagnosed much more definitively and clearly is to do a biopsy of the prostate. That's where we pass a needle through the rectum and into the prostate and take some samples. And we don't want to do that on every single person. Like I said, that can't be a good screening test because it's very invasive and it can cause a lot of pain and discomfort if done on every single person sort of indiscriminately. So this is where the PSA and the rectal exam come into play. With those two sort of basic screening tests, we can identify patients that might be higher risk and might be harboring prostate cancer. So, what are the causes of PSA to be elevated? There's, of course, prostate cancer. And I have to admit, PSA, it's not the best test in the world, but it's the best that we have. And there's ways that we can utilize it quite effectively. PSA can also therefore be elevated because of enlargement of the prostate, because of infection or inflammation in the prostate, what we call prostatitis, both of which are benign. It could be due to urinary retention. So sometimes you have an inability to pee and the urine's stuck in your bladder, you can't get it out. This can also be a reason why the PSA is high. So you think to yourself, you say, well, all these reasons why the PSA is high, how's that a good screening test? And I'll address that in a bit. It was also previously thought that if you were to ejaculate the night before you gave your PSA test, it might cause it to be artificially high. But now we know from research that that's not too significant of a difference, so we don't really advise against ejaculating before the test. A recent digital rectal examination, so if I was to do a rectal exam and send you for a PSA blood test, previously we thought that this would affect the level of the PSA, but now we know it's not that significant of an effect. Sorry. What are the causes of decrease? So is there some reasons why the PSA might be artificially low? And there's very few, in particular certain medications. So many patients in this room might take a medication called Avodart, dutasteride, or Proscar, finasteride. These medications are used to treat enlarged prostate and to help shrink the prostate. And these can sort of reduce the PSA value by 50% if you take it for more than 6 months. So this is one of the reasons why when we have you come into the office, we say, can you tell us all your medications? Because then we look at your PSA, we want to be able to know, is the patient on a medication that might be affecting their PSA? Is there another common question we get asked a lot, when we tell a patient, your PSA is kind of high. And the first question people ask is, what can we do to lower it? What can I do to get my PSA down? And unfortunately, there's no proven modifiable risk factors. In other words, there's nothing that you can really change. You can't change your genetics, you can't change your race, and so there's nothing really that you can change to bring your PSA down. How can we improve the accuracy or the utility of the PSA? So as I mentioned, you have all these different reasons why the PSA is up. So we got to try to find a way to make it really useful. So we look at the PSA in different manners. We'll look at the PSA relative to your age and relative to your race. So before, maybe 10, 15 years ago, we used to say 4 is the magic number. If you're above 4, it's abnormal. But now we know a little bit more where relative to your age, we'll have different cutoffs. And relative to your race as well, we might have different cutoffs. So this helps to improve its utility and accuracy. We also look at what's called the free to total ratio. So the PSA is found in the blood in different forms, either free-floating or bound to other proteins, and we can use that number to give us a little bit more information about the possibility of cancer versus not cancer. And then very importantly, we look at the PSA over time. How is it changing? Is it rapidly rising? Is it gradually rising? Is it stable or going down? And then we also look at the PSA relative to the size of the prostate. So if we feel on rectal exam your prostate's really large, then we know that, hey, maybe that's a reason why the PSA is sort of borderline. So a little bit, just quickly, there was a lot of controversy a few years back in terms of PSA screening, and it might be harmful for patients. So I thought I'd just touch a little bit on the research around it. There was a few big studies, 3 major studies that were done. This was in 2009. It looked at 76,000 men, and they compared screening patients with PSA and rectal exams versus not screening. And what they found was that there was no difference in the deaths from prostate cancer between the patients who were screened and not screened. And they followed these patients for 13 years. So this study showed that there wasn't really any benefit to PSA screening, but there was some criticisms against it. One was that the study only had about 94 prostate cancer-related deaths, so that's a really small amount to make any conclusions about the quality of PSA screening from PSA tests. The other was contamination. They found after the fact that a lot of the patients that were in the study were having their PSA checked elsewhere, and when they found it was high, they dropped out of the study. So this affects the quality of this study. The second major study that was done was 162,000 men, and they looked at a very similar sort of comparison, screening for prostate cancer and not screening. And this study found the exact opposite. They found that there was a 21% reduction in the risk of prostate cancer-related death. So the number needed to treat, we call. So if we were to treat 37 patients after finding prostate cancer, we would have saved 1 life. So that's pretty good in terms of research numbers. And this was from research that was patients that were followed for 11 years. There was criticisms against this study as well. They said that the study was done in multiple different centers in Europe. And so each center, some of them would screen once a year, some of them would screen twice a year, some of them would screen every 3 years. So there was some variability. And then the other criticism was the patients in this study were between the ages of 55 and 69. So can we apply this to younger patients and older patients? And then the third study was out of Sweden. Again, 20,000 men they looked at, and they screened patients for prostate cancer every 2 years with PSA and rectal exam. And this one found a very positive result as well. They said that there was a 44% reduction in prostate cancer-related deaths. The number needed to treat was 12 in this study. So if they treated 12 patients with prostate cancer, they would have saved 1 life, which is pretty good. Again, there was some criticisms against this study. They said the men were really young in this study, and they were all from Sweden. So it was just one ethnic population. Can we apply these results to the other patients of different ethnic background? As a result of these studies, there was a lot of hoopla in the U.S. back in 2012. There's a service called the United States Preventative Services Task Force, and they put out a statement saying that prostate cancer screening is harmful for patients. And a lot of this came because people that were being diagnosed with prostate cancer were sometimes being treated overly aggressively, and they were having a lot of side effects from treatment where they might not have needed it. Or they might not have done too bad if the prostate cancer was just left to be because they had a lower grade or a less aggressive prostate cancer. And then there was a Canadian task force on preventative health care, and this put out a statement in 2014. And they said that for men that were less than 55, PSA screening should not be done. For men that were greater than 70, PSA screening should not be done. And between 55 and 70, it was recommended against with a lesser they were saying that it wasn't as helpful, but they weren't recommending completely against it. So, the criticisms, why do people say that prostate cancer screening is bad? Well, it's because that the PSA test has been known to have a false positive rate. So out of every 1,000 tests, 100 might show your PSA is high when it actually isn't. And so this can result in some problems when we send the patient for a biopsy and they really didn't need it. The second criticism was the diagnosis of prostate cancer was being applied to a lot of patients, like I said, and they were being treated quite aggressively when maybe they didn't need it. The third criticism was that when they had these treatments, they were getting problems like erectile dysfunction and other heart problems from having a major surgery and so on. So the Canadian Urological Association, much like other urological associations around the world, refuted this and said, hey, there's a little bit more to the story than that's being put out there. First of all, they said that there's great evidence based on the studies that I was telling you that shows there's benefit in screening for prostate cancer and finding it early. Secondly, they said that with prostate cancer screening, ever since it was introduced, there was a 45% reduction in prostate cancer related deaths in Canada alone. And then the third was that in Canada, we were the birthplace of a treatment strategy we call active surveillance. So in patients that had small amounts of slow-growing prostate cancer, we opted to simply watch them as opposed to giving them radiation or surgery. And so this was a really groundbreaking development, and it's been adapted worldwide now ever since it was developed in Canada. And so because of this, the Canadian Urological Association said, hey, maybe we just need to be more particular about who gets treatment and how they're treated once we find the prostate cancer, as opposed to stop looking for it altogether. The other criticism was that these task force that were recommending against screening were mainly made up of people that, scientists and doctors that didn't necessarily have a background in prostate cancer. And so they were coming from a good place, but maybe didn't have the necessary knowledge in terms of first-hand experience of dealing with patients with prostate cancer. So, what are the recommendations? The Canadian Urological Association guidelines suggest that the harms and benefits of prostate cancer screening should be discussed with patients individually so that they understand the factors to be considered and their shared decision-making. So just like Dr. Manavari talked about, what's really important, what this whole night is trying to get you guys to be a little bit more active in your health. Talk to your family doctor. It's not necessary that you need prostate cancer screening, but you might benefit from it, and it's worth that conversation. We recommend, as per the Canadian Urological Association guidelines, we recommend screening be done with the PSA blood test and the rectal exam every 2 to 4 years for patients that are above the age of 50 and they have a life expectancy of at least 10 years. So this is a little bit tempered, where we're not saying screen every single person every single year, but we can select patients, again, based on that individual approach. If you have a family history of prostate cancer, so like I said, brothers or father, or if you're of black ancestry, then definitely you should consider being screened, and you might start earlier in this population and screen them maybe a little bit more regularly, maybe yearly, because their risk is higher. And that position that I just sort of presented is echoed by the American Cancer Society, the Canadian Cancer Society, the American Urological Association. So this is quite widespread now. And so the bottom line here, this is my little guy. I'd hate for you to throw him out with the bathwater, right? So let's not throw the baby out with the bathwater. What we can do is, talk to our family doctors and identify, because prostate cancer screening can be very useful in certain patients. And as long as we're being very judicious, we're being very smart about who's getting what type of treatment. We can use active surveillance where at least we're not letting the cancer run wild. And we're keeping a close eye on it, but we're also not subjugating you to aggressive treatments. So this is a very good option, and we use it quite commonly. And then the third thing is discuss. Just like we talked about, I've highlighted words here: individualized, involved, shared decision making. So that's the key. Talk about it, discuss it with your family doctors, discuss it with your urologist if you come in for other issues, and take it from there. Thank you very much.